Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Kemi Obajimi. Today's episode features expert perspectives on novel and emerging HER2-targeted and TROP-2 directed therapies for patients with breast cancer. This episode is part of a larger educational program titled HER2-low, HR-positive, and triple-negative breast cancer, expert training in real-world perspectives on novel HER2-targeted and TROP-2-targeted therapies. This podcast features Dr. Sara Tolaney, Associate Professor of Medicine at the Harvard Medical School and Chief of the Division of Breast Oncology at the Dana-Farber Cancer Institute in Boston, Massachusetts, and Dr. Melinda Telli, Professor of Medicine and Director of the Breast Cancer Program at Stanford University in Palo Alto, California. They will be discussing the real-world experiences and providing expert perspectives and pathological testing considerations for HER2 testing, optimal treatment of patients with HER2-low breast cancer, therapeutic landscape for patients with HER2-negative disease, strategies to optimize treatment outcomes and quality of life when using the FDA-approved antibody-drug conjugates for patients with advanced stage disease, and the emerging antibody-drug conjugates on the horizon. For more information on Dr. Tolaney and Dr. Telli, along with a link to the complete program, including the associated downloadable slide sets, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hi, and welcome to this Clinical Care Options program on HER2-low, hormone receptor positive, and triple-negative breast cancer, where we'll be talking about expert training and real-world perspectives on novel HER2-targeted and TROP-2-targeted therapies. My name is Sara Tolaney, and I'm a breast medical oncologist at Dana-Farber Cancer Institute, and I'm very lucky today to be joined by my colleague, Dr. Melinda Telli.
Hello and welcome, everyone. I am Melinda Telli from Stanford Cancer Institute.
Well, it's really nice to be able to do this with you today, Melinda. I'm looking forward to our discussions. There's a lot of work that has been done in this space, and so today we're going to be focusing on discussing HER2 testing and how we sort out the complicated arena of understanding HER2 expression. We'll talk about how to treat patients who have HER2-low, unresectable, or metastatic breast cancer. And we'll also talk about TROP-2 targeted therapies, as there's been a lot of changes in this landscape, and thinking about how to optimize outcomes and quality of life with these antibody drug conjugates that are available for our patients, and even touch a little bit about new ADCs that are on the horizon. So we'll start off with the challenges of HER2 testing. And so, Melinda, I'd love to get your thoughts on this, because this has been, I think, a little complicated for us, since we've always been used to thinking of breast cancer as either HER2 positive or HER2 negative. But so we've seen a lot of change in classification of disease. And so how has this really influenced your care, and how are you handling testing issues?
Yeah, I absolutely agree. I think if we go back, way back, trastuzumab was initially approved back in 1998. And since that time, for so many years, we were really focused on those tumors where there was a high level of HER2 protein overexpression or HER2 gene amplification. And those were sort of the patients that we considered for HER2 targeted therapy. And then everything really changed just in the last 2 years here, when we had the trastuzumab deruxtecan approved for this HER2 low indication. And so, I mean, it really was an important inflection point because this was the first therapy that was approved for tumors with HER2 low expression. And so the way, of course, in the trial that these patients were selected were if the immunohistochemical score, the protein expression, was at the 1+ or 2+ level. And for most of us, we've been getting those results reported out as a 0, 1+, 2+, or 3+ for a long time. But certainly there's been concern that our pathologists, if it was on the low end, they didn't give it too much extra thought in terms of whether they called it a 0 or 1+ or 1+ or a 2+. And I think a lot of that has changed. Now we are sort of bothering them quite a bit and asking all of these questions. Are you sure this is not HER2 low? And so, I think it's been an interesting time. Certainly we need to do better in terms of trying to characterize this biology better.
I totally agree. There was that one study by David Rim and his group that had looked at concordance. If you gave pathologists slides from HER2-0 and HER2-1+, and you gave, a bunch of different pathologists those same slides, how often would they read it the same way? And the concordance was, in the mid 20% range. So it's quite poor, which is a challenge. I just heard from someone that the rate of scoring slides as HER2-0 over the last 2 years has dramatically decreased because in essence, we're all trying to find patients who are HER2 low. And I think the pathologists now understand that. And so, it obviously just shows how challenging this really is. And so I guess knowing that, what are your thoughts about how you think things will change? I think one, we're likely to see data from Destiny Breast 06 that is coming out hopefully at ASCO this year, where we could see introduction of HER2 ultra low. And that could mean we have an option for T-DXd in this setting. And then two, there are lots of novel techniques that are being studied. So what are your thoughts? What would happen if DB06 were positive and we had benefit in ultra low patients? Do you think we can even define that? It's supposed to be someone who is staining that is between 0 and 1+. And right now I find it hard to believe we could figure that out because we have enough trouble discerning 0 and 1+. And so do you think we would clinically actually do that? Or how do you think that would change?
Well, I think it's going to be really interesting to see that data. I think my suspicion is that it will be of benefit in this ultra low group. Of course, there's some phase 2 data from the DAISY trial showing that, we see the highest level of activity with T-DXd in the HER2 high overexpressing category, but even activity responses in patients that came onto the trial with a HER2-0 score. And so I think it will be interesting to look at this data, look at that ultra low group. And I think it is going to be a challenge for pathologists, I think a challenge for clinicians, because we have, all of these patients in our practices with these historical biopsies that weren't kind of viewed and interpreted in light of these data. And so I certainly think we could, ultimately be in a future state where we are really considering the use of this drug in a broader group of patients and potentially not focusing so much on this HER2 scoring.
Yeah, it's true. I do wonder if T-DXd will start getting utilized more broadly across all comers in hormone receptor positive disease, if that's the case. Or two, if we will need to move to more quantitative methodologies so that we can sort this out. And, there are lots of novel ways that are being tested to score HER2 now, and including AI technology, RNA-based technologies, fluorescence, so lots of different things that are being evaluated. And I guess we'll have to see how the data all evolves. And so I think more to come here. But, you alluded to this challenge of how HER2 status can also change over time. And so maybe we could put this into a context with a clinical case and how you're actually handling this when you see patients. And so in this particular case, this was a patient who had originally presented with a node positive, hormone receptor positive cancer that at the time of diagnosis was IHC 0 for HER2. And she was treated with adjuvant systemic therapy, but unfortunately, 4 years after being on anastrozole, she developed recurrent disease with bone metastases. And a bone biopsy was done and confirmed hormone receptor positive disease, and IHC for HER2 was done and was IHC 0. So she started off getting fulvestrant and a CDK4/6 inhibitor, and then progressed and went on to get tamoxifen and everolimus, and unfortunately then progressed went on to get capecitabine. But then after being on capecitabine, she developed progressive disease now with liver metastases and further progression in her bones. So we've seen an original primary that was HER2-IHC0, and then now we've seen a biopsy, though, of a bone lesion that was HER2-IHC0. Is this someone you would think about doing another biopsy in, or what would you do in this particular situation, and how would you make a treatment decision for what to do after capecitabine?
Yeah, I think this is a common scenario that we see in practice. And certainly I would favor doing a repeat biopsy, and this time trying to go after the disease in the liver if it were feasible. The prior bone biopsy, I'm always somewhat skeptical of immunohistochemistry from bone biopsies. And of course, the original HER2-IHC was 0. But we do know, of course, HER2 expression, it's heterogeneous. There's this question of it, just that it's heterogeneity, or is there really some dynamic change over time? We saw some interesting data in a cohort of triple negative patients at ASCO last year, looking at basically the more you biopsy patients with recurrent disease, with each successive biopsy, about 1 in 3 are going to come back with a new HER2 low result that wasn't previously identified. And so, I think this is a patient has had frontline chemotherapy, is now being considered for second-line treatment, and this is absolutely the space where we would want to consider trastuzumab deruxtecan. And so I would try to biopsy her to see if there's a low result.
Yeah, no, I totally agree. I think we're always trying to see if we can find a HER2 low read, and I totally agree. And I'm never quite sure with the bone biopsy is obviously not an approved way to really assess for HER2 low with TDXD either. So definitely now with the liver lesion makes it much more attractive to try to get a tissue-based biopsy and see. And certainly if HER2 low, this would be second line treatment, and TDXD would seem like a really nice option here. But I think just goes to show how this is tricky in the clinic that we are now biopsying patients, I think, a bit more if we've not seen a HER2 low to see if they could be a candidate for therapy. So, thinking about the treatment landscape for patients with HER2 low disease, how has the results of DESTINY-Breast04 really impacted your practice? I don't know if you could tell us a little bit about your thoughts about the data and then how you've been utilizing it in the clinic.
Yeah, so, the study design was basically for those patients who had already received first-line chemotherapy for their metastatic HER2-low breast cancer, and they were eligible if they were to be treated in the second or third line. And of course, in that study, which randomized patients to TDXD or standard chemotherapy of physician's choice, we saw not only an improvement that was meaningful in progression-free survival, but also in overall survival. And so I think that if we look at that data and sort of how I interpret it, I want to use this agent as quickly as I can, typically. So after first-line chemotherapy, if the patient's eligible, I prefer to use it in the second line.
Totally agree. So, maybe we could think about a case because, now we do actually have a couple ADCs available to our patients. And so I think one of the challenges we're sometimes facing is thinking about what's the appropriate antibody drug conjugate, and then also thinking about potential sequencing. And so in this particular case, we have a patient who originally had de novo metastatic disease. So she had presented with a breast cancer that was hormone receptor positive and HER2-IHC1 plus. With a FISH that was 1.1, so it was HER2 low. Unfortunately, at that time, she had also been found to have mediastinal lymph nodes, which were biopsied and also hormone receptor positive, but the nodes were actually HER2-IHC0 with a FISH ratio that was also under 2. She did have genomic testing done, which revealed a PIK3CA mutation and a CDH1 mutation. There were no germline mutations. And given that she presented with metastatic hormone receptor positive disease, she went on to get endocrine therapy and a CDK4/6 inhibitor, so letrozole ribociclib. and upon progression went on to get fulvestrant alpelisib, given that she had that PIK3CA mutation. And upon progression on that, she went on to get chemotherapy with weekly paclitaxel, but eventually, unfortunately, also progressed, and at that time had peritoneal disease that was seen, as well as increased pleural thickening. And so a repeat biopsy was performed, which was hormone receptor positive and now HER2 IHC 0 with a FISH ratio of 1.1. And so how do you think about this? Because this is someone whose primary was HER2 1 plus, at the same time had mediastinal nodes that were HER2 0, and now upon progression after a line of chemo is IHC 0. Would you think about T-DXd for someone like this? Would you think about sacituzumab? How would you sort out what you would want to do here, given the dynamic nature of the HER2 status?
Yeah, so I think, this is an odd one because she had two biopsies at the same time of, the primary in the breast and then the metastatic mediastinal lymph nodes. And there was a, discordance there. One was a 0 and one was a HER2 low result. But I think for me, I look back at all of the historical results and I think there's just, so many concerns about heterogeneity, and with any given biopsy, are we really capturing the HER2 low area on that needle biopsy? And so I think if there's any prior HER2 low result, I consider that patient a candidate for T-DXd. And I think that is really in line with kind of the spirit of the trial and how patients were identified. It could have been from a metastatic site or from the primary tumor. And so I think for this patient, since she, again, had one line of chemotherapy with weekly paclitaxel, this is for the second line. I think this is absolutely, it falls where the T-DXd indication is for this type of patient. With sacituzumab govitecan, we do have an approval as well. Of course, we don't have to select the patients by TROP-2 expression. However, the, key point for this one is that if you look carefully at the label and the TROPiCS-02 clinical trial design, it was really for patients treated in the 3rd through 5th line. And so the approval is that, the patients have to have had prior endocrine-based therapy and at least 2 lines of chemotherapy in the metastatic setting. So, treating her with sacituzumab govitecan would sort of be off-label because it's not officially approved in the 2nd line for the hormone receptor positive.
Yeah, it is interesting because it's true in TROPiCS-02 is 2 to 4 prior lines of chemo, although technically they did count a line if you had early relapse. So the NCCN guidelines do allow you to use it in the 2nd line setting. So, here you could get away with it from a guideline perspective that, it is the guidelines to potentially use it here. But I agree that I also tend to take any HER2 low reading at any point in time to be an indication to think about T-DXd. And so I very much agree. It is interesting, though, and this heterogeneity of HER2 low status, is fascinating to me because it also makes you wonder, how the drug is actually working, right? Because if you have all these areas that are HER2 0 and we're seeing benefit, why is that? And you already alluded to the DAISY data that, I think we don't really understand mechanism that well here. And so, there was beautiful translational data in DAISY trying to understand this, but I think it is still an area that we're not fully understanding, but clearly can be effective. And so, I agree, would definitely think about it here. So, I think, again, we alluded to some of these TROP-2 directed therapies. You mentioned the TROPiCS-02 study with sacituzumab. This space is continuing to evolve as we are seeing some new kids on the block as well with other TROP-2 directed ADCs. And actually recently saw data from TROPION-Breast01 that had looked at datopotamab deruxtecan, also known as Dato-DXd, which is another TROP-2 directed ADC. In this case, has a deruxtecan payload, but that's also a topoisomerase 1 inhibitor. And so maybe, Melinda, I don't know if you could tell us a little bit about the data from TROPION-Breast01, and then how do you think about this with another TROP-2 ADC in this space, and how do you differentiate them?
Yeah, I think when sacituzumab govitecan was developed, we all had to learn about this target, TROP-2. It wasn't a target that we were used to thinking about, and it was really identified as just being highly expressed in a wide range of epithelial neoplasms, including at high levels in breast cancer. And it was really kind of a target really to just try to home that chemotherapy agent to the tumor site. But of course, it was very successful with the initial data in triple negative breast cancer, and then ultimately in hormone receptor positive HER2 negative disease, and then in other tumor types that, there has been great interest in continuing to develop agents targeting that protein. And so datopotamab deruxtecan, as you mentioned, that's the one that is furthest along. We saw some early phase data in the PanTROPION trial, which was sort of a basket study. There was a triple negative basket and a hormone receptor positive HER2 negative basket, and certainly it had activity in that setting. But a number of phase 3 trials were launched, and we just saw at ESMO in the fall the initial presentation of the TROPION-Breast01 trial. So this was basically hormone receptor positive HER2 negative disease for patients being considered for therapy in the second or third line. And this was, again, very similar in design to the other trials, the antibody drug conjugate versus chemotherapy of physician's choice. And what we saw was an improvement in progression-free survival. It was just over 6.5 months versus about 4.5, so about a 2-month difference in median progression-free survival. The overall survival was still quite immature. I think overall the data was quite immature. Median follow-up at the time of initial presentation was less than a year, but definitely a signal with this agent. I think we need to follow up, but the trial had dual primary endpoints, progression-free survival and overall survival, so it hit one of the primary endpoints. I think we're going to see a lot more with this one for sure. And then, there are many others, an agent, the MK2870, that I think we're going to be seeing more in clinical trials, again, also targeting TROP-2.
It's exciting to see more and more ADCs come out, which is great, although it sometimes makes it challenging for us to figure out which one to give a patient at a particular time. And so, if we put it into perspective with a case, so if we had a patient who presented with a triple negative breast cancer, although it was ER negative, PR negative, and HER2 IHC 1+, and at that time, unfortunately, presented with de novo metastatic disease, so had liver metastases, and the biopsy of the liver came back also triple negative, so ER negative, PR negative, and HER2 1+. This was a patient who did not have a germline genetic alteration, so did not have a BRCA mutation, did not have a PALB2 alteration, and came back with a tumor that was PD-L1 positive. So she went on to get first-line therapy with taxane and checkpoint inhibition, and had a response, but eventually progressed after about 10 months. And so now if you have a patient who's in the second-line setting who has a HER2 low tumor, what do you do for triple negative breast cancer? Here we have choice of sacituzumab or TDXT, and how do you decide?
Yeah, I think this one is a little different from the hormone receptor positive situation. And it really kind of comes down to just the overall level of evidence and quality of that evidence. Sacituzumab govitecan was approved, given its full approval based on the phase 3 ASCENT trial, which was a large trial, all triple negative breast cancer, and showed a very clear benefit for both progression-free and overall survival. So very good level of evidence for SG. But if we look at the DESTINY-Breast04, it was really largely a hormone receptor positive study. There was a small group of patients, just under 60 patients, with ER/PR negative HER2 low disease. And so while the overall benefit in terms of progression-free and overall survival were really in line with the larger population in that trial. I think that it's just not at the same level of evidence. And so when we have the choice here in triple-negative breast cancer, I would prefer and prioritize sacituzumab govitecan over T-DXd in the second line.
Yeah, no, I agree. I think, given the large phase 3 data from ASCENT, I totally agree that it seems like it has level 1 evidence for use in this setting and certainly makes sense. And then I think many of us do try to sequence these drugs just to make sure we give exposure to both. But I think this is where we're lacking in a bit of evidence to understand how these drugs truly work one after the other. There are prospective trials that will be evaluating this, but right now we just have small amounts of retrospective data, which is not so clear. So, we talked a little bit about Dato-DXd and the nice data we saw from TROP-1 and hormone receptor positive disease. What did you think about the toxicity profile? Because it's interesting to me that, with sacituzumab, for example, we see a lot of neutropenia and sometimes can see low-grade diarrhea, but, the Dato-DXd tox profile is completely different. I don't know if you could tell us a little bit about that, because it's so interesting that these drugs have such different side effects.
I think it is one of the really fascinating aspects of this. So it's the same target, a similar class in terms of the chemotherapy payload, and just a very different spectrum of toxicities. So with the datopotamab deruxtecan, what's been reported so far is that there is some GI toxicities, but it's not the nausea, the diarrhea that we're seeing with sacituzumab govitecan. It's more oral mucositis. That is really a prominent sort of adverse event. And there is some nausea, but it's really the mucositis that is the most prominent. Low rates of high-grade diarrhea, so different from sacituzumab govitecan. But we're also seeing some ocular toxicities with the Dato-DXd, which is, again, not a feature of sacituzumab govitecan. So overall, it appears to have less myelosuppression, less diarrhea, but certainly these other toxicities, the mucositis, ocular toxicity. I think, another feature that's different is just sort of the schedule. So this is dosed on day 1 of a 21-day schedule, where with the sacituzumab govitecan, patients are getting the treatment on days 1 and 8 of a 21-day cycle. So I think there is some, certainly patients prefer fewer treatments. And so, some advantage, I think, just in terms of the schedule.
Yeah, no, definitely. I think every 3 weeks is always nicer for our patients. And, I think we'll have to learn a little bit more about optimal management of toxicities. Obviously, we're hoping to see an approval for Dato-DXd, hopefully in the near term. And if so, there's a lot of work being done about using prophylactic mouthwash to help prevent that stomatitis with Dato-DXd. So, I think we're learning, and, I think the antiemetic prophylaxis seems to work pretty well with either 2 to 3 drug antiemetic regimens. But again, I think, as we get more experience, hopefully we'll get better and better at these things. But thinking more about toxicities with these antibody drug conjugates, obviously we've had T-DXd around for a little while now. How are you thinking about management with this particular drug? For example, what are you doing for nausea prophylaxis? And I think the other big question is, how often are you monitoring patients for potential interstitial lung disease? I know that's a controversial topic, and curious to know what you're doing about that one too.
Yeah, I think when clinicians got their hands on T-DXd, I think that it was pretty clear that the nausea was more prominent than we thought initially. And so I think I tend to, escalate my antiemetic prophylaxis for these patients. Nausea can definitely be an ongoing issue for some patients receiving T-DXd. And so sometimes I find myself escalating further, giving some low dose olanzapine, which I think tends to work well, but I typically do pre-medicate with aprepitant. And then I think in terms of other toxicities, fatigue, I do warn patients about the fatigue. Interesting, a lot of patients tell me that they feel that they tolerate it better over time, which is interesting to me. And then the interstitial lung disease or pneumonitis certainly has been identified as an adverse event of interest with this compound. And while in the clinical trials, the imaging was very frequent, every 6 weeks. I think that in practice, I'm imaging more on an every 9 to 12 week basis. I think that every 6 week CT imaging of the chest, it's challenging for patients, and also we get pushback from insurers. And so I think that that's certainly what I'm doing. There have been a few risk factors that have been identified for the interstitial lung disease, so older age, greater than 65, Asian ethnicities, and then interestingly, patients with abnormal baseline renal function. And so those are patients, if my patient has any of those risk factors, I will really watch them a little bit more closely. But I think selecting the patients and really educating them that it's a potential concern and for them to seek care should they develop any respiratory symptoms. I think that's a key part of giving this drug safely.
That's really helpful advice, Melinda. How do you think about, like, if you had someone, for example, who had, ground glass changes on imaging when you got your CT on T-DXd, do you get pulmonary involved, or how do you think about specialty consultation for evaluation? I know this is always tricky because we don't always have the specialists available right when we may want their help. What's your threshold, I guess, to seek consultation?
Yeah, I think, if it's a grade 1 pneumonitis, so sort of radiographic changes only in the absence of symptoms, the recommendation is to hold the drug and follow the patients carefully. Make sure you're, assessing their oxygen saturation. And if there's any deterioration, to start steroids. I think that, I would really consider involving a pulmonologist early in an asymptomatic patient, just looping them in if it's a large area of ground glass or an older patient, someone I'm worried about. Fortunately, in my practice, I haven't, encountered it much. I was fearful of it in the beginning when we first started giving this drug more, but it's not as common of a scenario as I was concerned in the beginning.
Oh, I'm glad you've had a good experience with things. And any pearls for how you manage sacituzumab? I think the biggest challenge I've obviously had with this drug is just the neutropenia. Do you ever give prophylactic growth factor, or do you wait for neutropenia to develop, or how do you manage that?
I tend to treat the patients with a day 9 pegfilgrastim because I feel that, they're going to run into problems. And so I sort of do that routinely. The diarrhea, I think there are plenty of patients that don't have any, and then there's some where it's more problematic. So making sure you talk to them ahead of time, talk to them about how to take loperamide or any other antidiarrheals. I think that, the overall, experience, it's quite variable patient to patient. There's some patients who I think do quite well with it. But, there's fatigue and, of course, pretty universal hair loss with SG. So all things you need to warn the patients about.
Well, that's very helpful. So, you've done a wonderful job teaching us about all these antibody drug conjugates for our metastatic patients. Do you think we're going to see these antibody drug conjugates move into the early disease space? What do you think? Do you think that's going to happen? Do you think it'll replace chemotherapy for our adjuvant or preoperative therapies?
I know it's all moving fast. I think that there is a good likelihood that these drugs can be beneficial in the high-risk post-neoadjuvant setting. We have different studies that are ongoing and where we're waiting results in the post-neoadjuvant setting across, triple-negative breast cancer and the HER2-positive space. But they are moving forward even more. So, looking at whether ADC therapy in the pre-op setting could replace, for example, chemotherapy in early stage triple negative breast cancer. So, I think these are going to be interesting trials to watch. I think all of these things were tried many years ago, of course, with TDM1, and we got it approved in the post-neoadjuvant space. But then a lot of the trials looking at that chemotherapy replacement idea, just didn't move ultimately, forward to an accepted approach for, preoperative treatment for HER2 positive breast cancer. So we'll see. I think interesting times ahead, but certainly these drugs are here to stay. We're going to be seeing more and more. It is really exciting. I think lots of new targets in terms of antibody targets. And then what I hope is that we're going to see more and more variety in terms of the chemotherapy payloads, given the concerns we talked about with resistance and sequencing ADCs with the same payload.
I totally agree. It's so exciting to see new options for our patients, and hopefully many more to come, as you allude to. So thank you so much, Melinda. I learned a lot. So thank you for doing this, and thank you to those listening to our podcast. We really appreciate it.
Thank you.
Thank you very much, Dr. Tolaney and Dr. Telli. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, HER2-low, HR-positive, and triple-negative breast cancer, expert training and real-world perspectives and novel HER2-targeted and TROP-2-targeted therapies on the Clinical Care Options website, please click on the link in the show notes. As always, thank you for listening.